Next, we have Gretchen MacCarrick from Johns Hopkins University. She'll be talking about aortic disease and genetic testing. What can it do for you? Gretchen MacCarrick is an assistant professor in the McCusick-Nathans Department of Genetic Medicine at the Johns Hopkins University. She has more than 20 years experience working in aortopathy disease. Her cardiovascular connective tissue clinic is passionate about translating results of clinical and laboratory research back to patient care and coordinating multidisciplinary expert care in these conditions. She also supports topics for the aortic disease population through her involvement in an advisory capacity for the Marfan and Loeys-Dietz Syndrome Foundations. Thank you, Professor MacCarrick, for sharing your expertise and passion for understanding the genetic underpinnings of aortic diseases. It is important knowledge for all patients. Please welcome Gretchen.
Thank you to everyone, especially to Amy and Pete. I will say that I do have a heart for this group and for Minnesota. I hope you'll forgive me that I transplanted to the East Coast, but I was born in Minnesota. I was a Golden Gopher. I'm from Duluth. So it's a pleasure to be back, but also my blood has thinned so much, it's so cold. I know, no. And thank you for the kind introduction. I have worked in the aortopathy space for about 20 years at Johns Hopkins, and so it's really a pleasure to be here. I'm only a little upset that I have to go after those incredible stories, and now you have to listen to some like nerdy scientific talk, but hopefully you'll learn some information. So pleasure to be here. So our agenda is to just talk some generally about genetic testing in the aortic disease space, to kind of go through some of the different syndromes and symptoms we think about that might prompt you a little bit more to head to a genetics clinic. And I wouldn't be a good genetic counselor if I didn't pull out some resources that are available for individuals. So big context, when we think about genetics, right, we're thinking about the instruction manuals that are telling our kidneys how to work, our heart how to function, our plumbing, our electrical systems in our heart. We have about 23,000 pairs of genes in the human body, but in perspective, we only really know about what 8,000 or 9,000 of them do in the human body. So only about 1/3 of our genetic information have we put together how that might impact what happens in our body. And then when we're thinking about aortic disease, we're down to about 38 to maybe 40 genes where we know if you have a mistake or a misspelling in that gene, it can impact how it works in the body. So we're really at the tip of the iceberg of learning the genetic etiologies behind aortic aneurysm disease. So who deserves genetic testing? The 2022 American Heart Association and American College of Cardiology came out with new guidelines that were actually very genetic friendly. So these guidelines are saying actually if you have an aneurysm and you're up to age 60, you should pursue genetic testing, especially in light of a family history, and especially in light of some of the syndromic features we're going to talk about. And actually some of the European guidelines even go up to 70 years of age. So when we think about aneurysms, we can think about syndromes versus non-syndromes. Syndromics means there might be some external clues or features that might say there's a difference in your connective tissue. So your connective tissue is the glue that holds you together. And in some people, that glue is a little bit weaker, and that glue can be found in your vascular tissues, but it can also be found in your skin, in your joints, in your bones. So kind of this is a schematic of head to toe issues where if you find that there are birth defects like cleft palate, club foot, scoliosis, chest wall anomalies that the chest wall pokes in or pokes out, if you have people in your family who are really hypermobile, ocular problems like really aggressive nearsightedness, retinal detachments, and even the skin can give us clues. Some individuals with connective tissue disorders can have very significant easy bruising, abnormal scarring. All those are some kind of external cues that there might be a syndromic connective tissue aortopathy in the family. So then we think about genetic testing. What is that? So genetic testing, back in the day when I started 20 years ago, we were hardly ever doing it. It was really expensive to get. There was like one gene. insurance was a big hassle. And now, for the genetic testing, the amount of genes we can test on one panel has grown immensely. As well, the cost has gone down and the ease has gone down. So genetic testing these days, we can often do it via a buccal kit or saliva kit like you do for Ancestry&Me or 23andMe that gets sent to your house. And it gets tested for sequence or DNA changes in about these 40 genes or so. We're not looking for Alzheimer's or other cancer predispositions. We're really doing it for this dedicated reason. There can be different panels through different labs, but they are all under CLIA approval and very reputable labs. This is not, we get this question, this is not sequencing.com. So there are some Instagram posts where you can get your full genome sequenced for $400, and this is not that sequencing. If you really are interested in clinical genetic testing, you have to get it through a genetic counselor or a geneticist. You can't make these diagnoses on those at-home direct-to-consumer tests. And so when we're thinking about testing for aortopathies, we're pretty good at finding many of the genetic causes for those syndromic conditions. Not so great, we'll talk about bicuspid aortic valve and ascending aneurysm, which probably impacts a lot of people here. Not so great about finding those genes, it's kind of the holy grail. And for bicuspid aortic valve and ascending, it may indeed be that it's not one single gene change, one single gene that causes it. It might be a whole bunch of small gene changes that cause that, and we're just not at that point of technology to be able to detect that yet. Importantly, sometimes on these aneurysm panels, because we put a whole bunch of genes on them, there might be some genes that are actually not as applicable to you, where individuals might have to have very aggressive scoliosis at birth or intellectual disability. But because it's easier and cheaper to put them all together, it is all on one panel. And this comes into play because when we do this type of genetic testing, it's not like a CMP or a blood count where you get a specific number. We're doing DNA sequencing of the genes and trying to compare it to like what is quote unquote normal. And so when you're doing genetic testing and we're sequencing these genes for about 40 genes, you can get a negative test result, means that there was no variance found in the testing. Doesn't mean it's not genetic, just means as of 2025, in these 40 out of 23,000 genes that we tested for, there was no genetic answer. You can get a positive test, a pathogenic or likely pathogenic variant. So this is a gene change, it stops the gene from working. We're like 100% confident this is the predisposition to aneurysm. It helps us take care of you better. It gives us rules and tools which we'll talk about, excuse me. And also then it gives you information for family screening. So if we find a specific DNA reason why the aneurysm is occurring, we can go to siblings, parents, children, and test for that specific variant. And then sometimes on this testing, we get what's called a variant of uncertain significance. So this is a DNA change where we're not 100% sure it's the answer. We're not 100% sure we can blow it off as like a rare Asian, English, Scottish variant. And so in those cases, we do our homework, right? We say, how prevalent is it in the population? How many people are walking around with it? Does it track in the family? You know, if you have a sibling who also has an aneurysm, do they carry that same variant? So we do a lot of homework not to leave you in an ambiguous situation. Again, if testing is negative, however, it's really important to talk about family screening. In about 20% of cases of someone with an aneurysm, there is a positive family history of aneurysm in the family. And so if you don't have a genetic test to offer a family member, echo screening is really recommended for all first-degree relatives. This would look at the valve morphology, right, for that tricuspid versus bicuspid valve. It'd look at the aortic root diameters, and would look at the ascending aortic diameters. It's important to know in some of these conditions as well, like the bicuspid valve and ascending, if your child or sibling gets a normal echo and they don't have the bicuspid aortic valve, it's really important that they continue to get intermittent echo screening for the aortic dilation. That aortic dilation can develop over time, even independent of bicuspid aortic valve when you look at those families. And so one normal echo screen for that BAV should not rule out disease, and so those individuals definitely deserve echoes about every 3 to 5 years if normal. So the why. Why pursue genetic testing? One, it helps us test other family members, not only family members that are here, but especially for family members who are considering a pregnancy. They could test the pregnancy through a CVS or amnio when the woman is already pregnant, to be prepared to deliver at a different hospital if needed. But there's also technologies that allow you to do an IVF procedure and create embryos in a lab, and then try to pursue a pregnancy with the embryo that is negative for the aneurysm risk, to remove that risk from the family member. It helps us with surgical thresholds. So many of you have maybe heard of that 5 centimeter mark, where that is kind of the magic number where people think about having their aortic surgery. But there are some genetic predispositions that actually bring that surgical threshold down to 4 or 4.5 centimeters. So it helps us think about when is the right time to do surgery. It helps us think about imaging. What do we need to look at and how frequently? So some of these genetic conditions we'll talk about, the risk is really the thoracic aorta, but some of these conditions can put you at higher risk for brain aneurysms or aneurysms going to the kidneys or the legs. So if you have one of these genetic conditions, we're gonna MRA or CTAU head to pelvis every few years to keep you safe. It can help us with medical therapy. So I think there's a pharma talk a little bit later today, but there is some evidence that in some genetic predispositions, certain blood pressure medications may be a little bit better to use as a first-line defense. So many people get put on a beta blocker or an angiotensin receptor blocker, but due to the biochemistry of some of these genetic conditions, we might say, gosh, that angiotensin receptor blocker, it is helping the tissue from the inside, not just that hemodynamic blood pressure stress. So it helps us really strategize a better medication regimen for y'all. And then it can also help us with non-vascular guidance. So some individuals in some of these conditions might be at risk for orthopedic concerns or allergic concerns, and so it helps us kind of think of you as a whole person. So you've also heard earlier today about like precision medicine or personalized medicine, and actually the aortopathy space is a space where this has kind of come to fruition, where we know that there are guidelines, and guidelines are for the general person, right? But with the person sitting in front of us with aortic disease, we can really help tailor all of this care depending upon the family history. How many people in the family have had aneurysms? Has there been young sudden death? Has there been death due to dissections at smaller dimensions? We can make personalized recommendations based on the gene change that you have, not only the gene change, but the gene itself. We also take into account how fast is the aorta growing. Again, what is that absolute dimension? What does your genetics tell you about that surgical threshold? And then there's some really interesting science going into other what's called biomarkers or imaging markers that might put you in a more aggressive versus less aggressive category. So in our disorders, there's a lot of research into what's called vertebral tortuosity and or carotid tortuosity. These are the neck vessels that go up, and they should be pretty straight, but we know in some aggressive aneurysm conditions, they might be a little bit more windy. So we're getting to the extent of like how your blood vessels in your neck can help predict risk of dissection, which is pretty crazy when you think about it. So kind of the big, I guess 3 or 4 aneurysm syndromes that we think about. One, if you Google aortic aneurysm, you might have all come across Marfan syndrome. So this is a dominant condition, so it can get passed on, from a parent to a child. It is caused by gene variations in a gene called fibrilin-1. These are individuals who might be have a tall, thin body habitus, kind of shorter trunks, longer arms, fingers, legs. They can have an eye finding called ectopia lentis, or where the lenses kind of scoot around or sublux a little bit. They can have scoliosis, chest wall anomalies. These individuals are primarily at risk of aortic root aneurysm and tear. And so these are individuals with a disorder that is kind of a cousin to Marfan syndrome called Loeys-Dietz syndrome, or LDS. LDS was described and discovered at Johns Hopkins 20 years ago. We're celebrating the anniversary. And many individuals with Loeys-Dietz syndrome can have syndromic external features, but many people you might walk down the street and not even recognize. There's actually 7 genes for Loeys-Dietz syndrome. And there can be quite variable expressivity. So that means that you can see Loeys-Dietz syndrome in young kids who here present. You can see they have a little bit wide-spaced eyes, really translucent skin. You can see their veins, might have club foot, cleft palate. They can have cervical spine abnormalities, so really important to get this diagnosis so we protect their cervical spine. But then also you can have later adult onset, where individuals might not have those external features, but are still at risk for aneurysms throughout the body and early dissection. So really key to make this diagnosis. And this is a disorder where we bring down those surgical thresholds. There's a group of conditions called familial thoracic aortic aneurysm and dissection, or FTAD. And these are individuals who you can see in the family, clustering of aortic aneurysm and dissection primarily, maybe some cerebral vascular disease like strokes or early onset coronary artery disease. And these individuals tend not to have a lot of external features, but they have gene changes in these genes that are expressed in the vascular smooth muscle. So the way that your arteries and your aorta responds to blood pressure changes, that mechanism cannot work as effectively. The most common is caused by variations in the ACT2 gene. Here you can just see kind of a clue is that livedo reticularis. So that's like that kind of honeycomb modeling. It has to do with your capillaries, and that vascular smooth muscle in your capillaries can be a clue. But these are individuals who might be at risk of stroke or cerebrovascular disease, so we want to pick them out too. And another very aggressive familial thoracic aneurysm disease is called PRKG1. And so this is a disorder where people can show aneurysms that rupture at normal diameters and at pretty young ages. And so if this was a diagnosis in a family, we would be very aggressive when individuals get into their 20s or so to really talk about very early surgical intervention. And again, both of these have impacts on your surgical thresholds. And then 2 more conditions. One is called vascular EDS. And so vascular EDS is a condition where you're likely not going to see aneurysm dissection, aneurysm thoracic dissection all in a family. You're going to see a cerebral hemorrhage and a sudden death and a splenic artery dissection and an aortic dissection. These individuals can have spontaneous arterial and aortic dissections. They can also have spontaneous hollow organ ruptures, so bowel ruptures. So this is very important to make a diagnosis of, so you can get very acute care in an emergency setting. And then clearly, people have touched upon bicuspid aortic valve and aortic aneurysm. Bicuspid aortic valve is quite common in the population, about 1% to 2%. It is a subset of that population that can go on to have aneurysm, typically ascending. So, right, the root is the first part of that candy cane of the aorta. The ascending is a little bit distal. But it's important to know that when you start echo screening family members, you can see bicuspid valve alone. You can see just aneurysm. You can see both. And in a small minority of cases, you can see some really severe left-sided heart defects, like hypoplastic left heart or congenital aortic coarctation, so where babies would be born and need surgery right away. So that's why it's important to make this diagnosis, so people are getting fetal echoes if they're pregnant, etc. Again, the holy grail of genetics. It might not be one genetics, but we're not as great about knowing it. We know about 1 or 2 genes, maybe about 1% of BAV and aneurysm. And I just want to point out 2 resources that I think you have access to today. So I have some books out there. I got a grant from the John Ritter Foundation 2 years ago, and what was going to be a short brochure ended up being like an 80-page mental health resource. So if anyone would like some, oh, thank you. There we go, my Vanna White moment. I will have a whole bunch at the table. Please, please come and get them because they're heavy and I'm not bringing them back on the airport plane with me. And so I think I applaud everyone here, and it makes my heart really happy because I love patient stories. And I think as a genetic counselor, one of my jobs is to bring attention to mental health, PTSD, anxiety, depression, making sure people are getting into cardiac rehab, getting those mental health resources, getting that pain management they need, and sharing their stories with their families and others. So that's why I'm really, really honored to be here. So come check that out. And then you'll see the Aortic Hope resource, the aortic dissection, the patient guide, and this is really great. It's broken up into kind of 3 sections: living with aortic disease or dissection right afterwards, kind of the long term, and also for family members. And I think the Aortic Hope group has some of these books out there as well, and you can get them on their website. But 2 really great, just like patient empowerment tools that I would encourage you to use. So again, thank you so much. Sorry if I went a little bit over, but we'll be back for questions, and come meet me at the table afterwards. Thanks.